The glucose is an important carbohydrate available to the body for various purposes. The carbohydrates which are taken through the diet are acted upon these several enzymes and ultimately converted into glucose. Glucose is the primary energy source for human body. RBC and brain tissue mainly depends on glucose for their energy requirement. There are two sources of glucose: exogenous source, the carbohydrate from the diet, the starch of vegetable, grains, liver, and muscles. The endogenous source, the stored liver, glycogen, proteins, and other non-carbohydrate like glycerol and lactic acid, which are available in the body. Chemistry definition: the carbohydrate are defined as a polyhydroxy alcohol with free aldehyde and keto groups. Classification: monosaccharide. These are the simple sugars. Monosaccharide are further subdivided into triose, tetrose, pentose, hexose depending on the number of carbon atoms present. They contain an aldehyde or keto groups. Those containing an aldehyde group or aldose sugars, and those with keto group or keto sugars. Disaccharide. These are the molecules containing two same or different monosaccharide units. On hydrolysis, they yield two monosaccharide units. Two monosaccharide units are joined by the glycosidic bond. Polysaccharides. These are polymers of same monosaccharide units. They are classified into homo and hetero polysaccharides. Homopolysaccharides. Example: homopolysaccharides are sugar, dextrin, glucose, cellulose, inulin. Starch is a mixture of two polysaccharides, amylose and amylopectin. The major difference between the amylose and amylopectin is amylose unbranched and linear. Blue color formed because of iodine molecules are trapped inside the helical structure. The color disappears upon heating and reappears upon cooling. Amylopectin is highly branched. The branch point appears after every 24 to 30 the glucose unit in a straight chain form and gives a reddish violet color with iron. Heteropolysaccharides. These are made up of more than one type of monosaccharide derivatives. Example includes hyaluronic acid, chondroitin sulfate, heparin, keratin sulfate, heparin sulfate, and dermaton sulfate. Digestion of carbohydrate. The diet of human body contains carbohydrate, fats, and proteins, which are complex compounds of high molecular weight. They are absorbed only when they are hydrolyzed to simpler forms. The major carbohydrates of our diet, such as starch and glycogen, are polysaccharides. These polysaccharides are hydrolyzed to maltose and glucose by the action of several enzymes. The digestion of carbohydrates starts in the mouth. Salivary amylase hydrolysis alpha 1 to 4 glycosidic linkages randomly within the polysaccharide chains and produces a disaccharide and monosaccharide. After the food reaches the duodenum, the pancreas amylase also helps to digest polysaccharides. Further digestion takes place in the small intestine by the intestinal enzymes which hydrolyzes a terminal alpha 1 to 4 glycosidic linkage. At the same time, the disaccharides like maltose, lactase, and sucrase digest disaccharides like maltose, lactose, and sucrose respectively into their respective monosaccharide units. Digestion of important food products. Although cellulose is not digested further, it helps in easy peristalsis and provides bulk to the feces. Lactate deficiency leads to the lactose intolerance. Absorption of monosaccharide. After digestion, all the monosaccharides are almost completely absorbed from the small intestine. Galactose and glucose are absorbed very rapidly by the active process, which is linked to transport of sodium and requires energy in the form of hydrolysis of high energy phosphate bond in ATP. The glucose cannot diffuse through the lipid bilayer of the cell membrane because of polar nature. The absorption from the intestine level into the intestine cell is by the co-transport mechanism called sodium dependent glucose transporter. It occurs against the concentration gradient and it requires a carrier protein. Utilization of glucose. The glucose molecules undergoes several metabolic pathways such as storage, oxidation, synthesis of fat, conversion to other carbohydrate, and conversion to amino acids. Storage. Carbohydrate when taken in excess through the diet is deposited as a glycogen in various tissue, especially in liver and muscles. Remaining glucose is converted to fatty acids and stored as triglyceride. Oxidation of glucose. The carbohydrate undergoes three types of oxidation depending upon the nature of the tissue and availability of oxygen. Complete oxidation. If more dependent for energy, glucose may be completely oxidized to carbon dioxide and water by glycolysis and TCA cycle. Hexose monophosphate shunt. The phosphate pathway. In certain tissues such as adipose and liver tissue, glucose may be degraded to carbon dioxide in various reactions involving pentose glycolysis. At a certain time in muscles, especially during the exercise, glucose is partially oxidized to lactic acid by glycolysis. This is called anaerobic glycolysis. The lactic acid is deposited by the tissue, especially the liver. The oxidation of glucose to pyruvate in the presence of oxygen is called as aerobic glycolysis. Conversion to fat. The amount of the glycogen that is stored in the body is limited. Thus, the remaining glucose will be converted into fats. The fatty acids then forms fats and stored in adipose tissue. Conversion to amino acids from glucose or its metabolite. The carbon skeleton of some of the non-essential amino acids is derived. The conversion to other carbohydrate. Small amount of glucose is also converted to other useful carbohydrate. They are ribose and dextrose required for the synthesis of nucleic acid. Mannose, fructose, galactosamine, uramic acid form part of amino polysaccharide and glycoproteins. Glucuronic acid involves in the formation of mucopolysaccharide and detoxification reactions. Galactose, a component of lactose. Metabolic pathway. A metabolic pathway consists of a series of enzymatic reactions to produce a particular product. The process of metabolism is divided into aerobic pathway and catabolic pathway. The anabolic pathway refers to the biosynthesis of a particular component. The catabolic pathway refers to the breakdown of a particular component. In carbohydrate metabolism, glucose is a central molecule since most of the metabolite pathway of carbohydrate are linked with the major pathway. The major metabolic pathway of carbohydrate are glycolysis, oxidation of glucose into pyruvic acid or lactate, Krebs cycle, oxidation of acetyl-CoA into carbon dioxide. This is the final common oxidation pathway for carbohydrate, proteins and lipids through the acetyl-CoA. Glyconeogenesis, the synthesis of glucose from the non-carbohydrate source. Glucogenesis, synthesis of glycogen from the glucose. Glucogenolysis, breakdown of glycogen into glucose. Hexose monophosphate shunt pathway. Glucose is oxidized to carbon dioxide and water. Minor pathway. Uronic acid pathway. Glucose is converted into glucuronic acid and pentose. Galactose metabolism. Here there is a conversion of galactose into glucose and synthesis of lactose. Fructose metabolism. Here the oxidation of fructose into pyruvate takes place. Amino sugars and mucopolysaccharide metabolism. Here the synthesis of amino sugars and other sugars for the formation of mucopolysaccharide takes place. Glycolysis. This is also called as a Embden-Meyerhof Paranas pathway. The term glycolysis is derived from the Greek word glykeis, meaning sweet, and lysis meaning spilling. Glycolysis is defined as a conversion of glucose into pyruvate in aerobic conditions or lactate in the anaerobic conditions. Along with the production of small quantities of energy. All the reactions of the glycolysis take place in the cytoplasm of the cell. Significance of glycolysis. It is the only pathway occurs in all cells of the body. Glycolysis is very essential for brain, which is dependent on glucose for energy. Glycolysis is the only source of energy for erythrocyte. During heavy exercise, when there is insufficient oxygen for muscle tissue, oxygen is obtained mainly through the anaerobic glycolysis. The glycolysis pathway also provides the carbon skeletons required for the synthesis of non-essential amino acids and glycerol. Gluconeogenesis. The synthesis of glucose from the non-carbohydrate source is called as a gluconeogenesis. The main non-carbohydrate source are lactate, pyruvate, glucogenic amino acids. The minor source are propionate, glycerol. The gluconeogenesis occurs mainly in the cytoplasm of the liver cells. A small amount of gluconeogenesis occurs in the renal cortex. Significance of glyconeogenesis. A continuous supply of glucose is required for the brain and cerebral central nervous system, erythrocyte, testis and renal medulla. The human brain alone requires about 120 grams of glucose per day. The major metabolic significance of gluconeogenesis is the maintenance of blood glucose level under the condition of starvation. On prolonged starvation, gluconeogenesis is speed up. At the same time, there is increased lipolysis and protein catabolism, which provides a substrate for gluconeogenesis. Under the anaerobic condition, the glucose is the only source of energy for skeletal muscles. When certain metabolites such as lactate, glycerol or etc. accumulate in the tissue, glucose synthesis is effective way of reducing their level. Glycogenesis. The synthesis of glycogen from the glucose is called glycogenesis. The glycogen is a stored form of a carbohydrate in the human body. The glycogen is mainly stored in the liver and muscles. After meal, excess glucose is converted into glycogen for the purpose of storage. The glycogen is present in the form of granules in the cytoplasm of liver and muscles. The main enzyme in the synthesis of glycogen is glycogen synthetase. glycogenolysis. The breakdown of glycogen into glucose is called as a glycogenolysis. It takes place in the cytoplasm of the liver and muscle cells. The main enzymes in glycogenolysis is glycogen phosphorylase. The branch of glycogen is removed by debranching enzymes. Determination of glucose in the body fluid, blood, urine, and CF. There are many methods available to measure the blood glucose level. They are enzymatic method, hexose method, glucose oxidase peroxidase method, GOD, POD, glucose dehydrogenase method, polarographic method, PO2 electrode method, chemical method, toluidine method, Fordin-Wu method, Nelson-Somgi method. Sample collection processing. The blood sample is collected and processed. The selection for the serum plasma depends on the method used. The serum is free of fibrinogen. Plasma contains fibrinogen. The fasting whole blood glucose concentration is 12% lower than plasma glucose. Usually, the venous blood samples are used for the glucose estimation. If the serum is used, then the assay should be done within 30 minutes of the sample collection. Since it does not contain any preservatives to stop the process of glycolysis, the glycolysis decreases serum protein glucose by 5 to 7% per hour in a normal uncentrifuged blood kept at a room temperature. Glycolysis can be inhibited by addition of sodium iodoacetate or sodium fluoride with stabilizing the glucose level. Fluoride ion prevents the glycolysis by inhibiting the enzyme enolase. Fluoride is also a weak anticoagulant because it binds to Ca2 plus ions. Potassium oxide 2 grams and sodium fluoride 2 milligram per ml of the blood are added to prevent clotting. The vac container available contains fluoride. The blood glucose does not done at 3 intervals. Fasting blood glucose is estimated 8 to 10 hours after the last meal. This is usually done in early morning. The person should not consume anything other than water. Postprandial blood glucose is estimated usually 2 hours after the normal meal or breakfast. The random blood glucose can be measured at any time of the day irrespective of the food taken. Enzymatic method, hexokinase method. Glucose is phosphorylated to glucose 6-phosphate by ATP in the presence of hexokinase and activated by magnesium. The glucose 6-phosphate formed is oxidized by glucose 6-phosphate dehydrogenase to give 6-phosphoglucanolactone in the presence of NAD. During this reaction, NAD plus is converted to NAD plus H plus. The amount of NAD produced is directly proportional to the amount of glucose present in the sample. Glucose 6-phosphate dehydrogenase derived from the yeast is usually used in the assay, which uses NAD plus as a coenzyme. NAD plus is a coenzyme for the bacterial glucose 6-phosphate dehydrogenase. NADH produces is measured at 340 nanometer. Glucose by ATP gives 6-phosphate plus ADP. Note: NAD plus can be used instead of NAD. Plasma is deproteinized by adding solutions of barium hydroxide and zinc sulfate. The clear supernatant is mixed with a reagent containing ATP, NAD plus hexokinase, glucose 6-phosphate dehydrogenase. The mixture is incubated at room temperature at 25 degrees Celsius until the reaction is completed and NADH produces is measured. The standards are and the reagent bank run simultaneously with the sample. NADH formed is measured spectrophotometrically at 340 nanometer. The formation of NADH is proportional to the glucose concentration. Bilirubin, lipids, and some drugs may interfere with the enzyme. The procedure is linear up to 500 milligram percentage of glucose concentration. If the concentration is 500 milligram percentage, the sample must be diluted with a normal saline in the beginning of the assay. Glucose oxidase peroxidase method. So the enzyme glucose oxidase catalyzes the oxidation of glucose to gluconic acid and H2O2. Addition of enzyme peroxidase splits H2O2 to glucose to water and nascent oxygen. The oxygen oxidizes the added colorless chromogen orthodiazepinate to a colored product which can be read colorimetrically. The intense of the color formed is directly proportional to the glucose concentration. This method is highly specific and gives an accurate glucose value. The glucose oxidase will act only on beta glucose. Many of the laboratories use this method to analyze glucose using analyzers. The commercial available GOD POD kit can be used to analyze the blood glucose using the calorimeter. This kit contains working and standard solution. The procedure for a manual estimation of kit is as follows: mix the incubator 37 degrees for 15 minutes at room temperature for 30 minutes and read the absorbance of the tested standard reagent and refine not 5 with a green filter against distilled water. Calculation 80 minus AB divided by AS minus AB into 100. The standard glucose oxidation peroxidation method can be used in the laboratory. Standard calorimeters graph plotting the various concentration of standard and the concentration of blood glucose. The test sample is determined. Advantage is the true glucose page 75. The true glucose value are obtained by this method since it's specifically oxidized glucose to give gluconic acid and has a very little effect on other sugars. This method is unaffected by the other blood constituent. This method is sensitive and it's applied to various automated analysis. This method is useful to measure CSF glucose. Disadvantages: the glucose oxidase method are not applicable where directly to urine samples owing to high concentration of peroxidase inhibitor and other interfering substances. Uric acid, ascorbic acid, bilirubin, glutathione, and tetracycline will interfere with this assay. The glucose dehydrogenase method. The enzyme glucose dehydrogenase catalyzes the oxidation of glucose to gluconolactone. Since the enzyme GDH is specific for beta D glucose and enzyme mutaroatase is added to shorten the time required to reach the equilibrium. The amount of NADH produced is directly proportional to the glucose concentration, which is measured at 314 nanometer. The reaction highly specific for glucose. The reaction is not interfered by anticoagulant and other substances which are normally present in the plasma. The absorbance is usually linear with the glucose concentration up to 1000 milligram percentage. The leptemic samples causes interference. Blank set with a normal wave for leptemic sample. The procedure is not widely used. Chemical method, orthotoluene method principle. Orthotoluene is a glacial acetic acid which when heated with glucose produces a color complex with an absorption maximum 630 nanometer. The aldehyde group of the glucose apparently condenses with the amino group of O-toluene to form N-glycosamine and skip base, which gives us a blue color product. This reaction is not specific for glucose and other aldohexoses with like mannose and galactose gives will also react, but these aldohexoses are usually present in very small amount. The reagent thiourea is added to stabilize for the stabilization of color. So venous blood is collected in an oxalate fluoride coated tube. Specific advantages: this method can directly apply to serum or plasma, CSF, and urine. Therefore, whole blood of a homolyzed sample deprotonization with the TCA is required. The color of the reaction mixture is stable for up to 45 minutes and then color slowly decreases. Among non-enzymatic methods, this is most widely used because of high specificity and simplicity. Disadvantages: bilirubin may interfere because of a partial conversion of bilirubin, which is green in color. If the patient is uremic, high values are obtained with this method. Standard graph: the glucose can be estimated even by plotting the standard graph. This method is helpful for students to learn more about pipetting and plotting of graph with the different concentration of glucose ranges from 50 milligram to 400 milligram. The reagents are same as explained in the above method except the standard glucose working standard. For Foulin-Wu method principle, the protein is removed by using a tungstic acid. The protein free filtrate containing glucose reduces alkaline copper reagent. Phosphomolybdic acid added developed a blue color. The optical density of the blue color is measured with the colorimeter using the blue filter 490 nanometer. Other reducing substances present in the blood will give us a positive result. This includes glutathione, uric acid, glucuronic acid, and ascorbic acid. Nelson-Somghi's method. In this method, the protein are precipitated by using the equal volume of barium chloride, barium hydroxide, and zinc sulfate. The interfering substances are removed along with the precipitate. The result obtained may be more accurate, better than result obtained from the Foulin-Wu method. The method alkaline copper tartrate reagent is stable. The method gives a result near the true glucose value. The disadvantage is that a little excess of either barium or zinc sulfate causes a lot of error in the estimations. Normal range: fasting range 80 to 100 milligram per percentage, postprandial 90 to 140 milligram percentage, random 90 to 150 milligram percentage, newborn 40 to 90 milligram percentage. The CSF glucose concentration is about 40 percentage of blood glucose value, and simultaneous measurement of the blood glucose estimation is required along with the CSF. Glucosuria: the presence of reducing substances in urea is called glucosuria. Presence of glucose in urea is called glucosuria. The presence of fructose in the urea urine is called as a fructosuria. Presence of lactose in the urine is called a lactosuria. Reducing substances which are excreted in the urine as are glucose, fructose, lactose, galactose, and pentose. The normal carbohydrates which are known to have reducing activity are homogenic acids, salicylic acid and ascorbic acid. In normal condition, glucose does not appear in the urine. Different types of glucosuria are seen. Hyperglycemic glucosuria. Hyperglycemia is most common cause of excretion of glucose in urine. When the blood glucose level exceeds a renal threshold value of 180 mg per deciliter, the glucose may appear in the urine. Hyperglycemic glucosuria is commonly seen in diabetes mellitus patients. Renal glucosuria, the excretion of glucose in urine due to the decrease in renal threshold is called as a renal glucosuria. In these cases, the glucose tolerance is normal. The blood sugar level or within the normal limit. The renal threshold is decreased in pregnancy. This can also occur due to the renal threshold deficiency. Alimentary glucosuria. This is seen in person with sudden absorption of glucose from the intestinal tract. As a result, it appears in urine. This is called as alimentary glucosuria since alimentary canal is involved. Transient glucosuria. In some person, glucose may appear in the urine due to the certain emotional stress condition like anger and anxiety. These conditions excessive secretions of catecholamine may lead to the hyperglycemia and fructosuria. This is linked with the fructokinase deficiency of hereditary fructose intolerance. Galactosemia. This is seen in galactose 1-phosphate uridyl transferase deficiency. It is a rare congenital disease in infant. Galactose accumulates in the blood leads to the galactosemia. Galactose excreted in the urine called galactosuria. Lactose is found in the urine of normal pregnant women during the third trimester of pregnancy and lactation. It is the second most common type of glucosuria. In pregnant with suspected gestational diabetic mellitus, it is very important to differentiate lactosuria from galactosuria. Quantitative test for glycosuria. Bentic reagent is used for this reagent containing copper Cu2 plus ion complexes to citrate in alkaline solution. Reducing substances converts Cu2 plus ion into Cu plus ion, forming a yellow or red color. Semi-quantitative measurement of glucose. The enzyme coated paper strip are commercially available. The strip is dipped into the urine and the color is examined after 20 to 30 seconds and compared with the standard. The glucose oxidation peroxidase method is this principle lying behind this method. Quantitative test for reducing sugar. Selwang's test for fructose in urine. The Selwang's reagent 3 ml and 0.5 ml urine are boiled for 30 minutes. A red color appears in the fructose present. Methylene test for lactose. 5 ml of urine is added. 1 ml of methylene hydrochloride and 1 ml of sodium hydroxide are added and kept it at 56 degrees Celsius for 30 minutes. An appearance of red color indicates the presence of lactose. Mucic acid test for galactose. When urine is boiled with mucic acid crystals are formed indicating the presence of lactose or galactose. Bile test for pentose. 5 ml of bile reagent is boiled with 0.5 ml of urine and a green color is formed produced if the urine contains pentose. Fructose determination in serum. Resourceline 100 milligrams of resourceline is dissolved with 250 ml of thiourea in 100 ml of lactic acidic acid. HCl 20 ml of concentrated HCl made up to 100 ml with water. Stocks the fructose stock standard. Fructose 100 milligram in 10 milligram 10 ml saturated benzoic acid. Working standard 0.1 ml per milligram per ml dilute 1 ml of stock to 10 ml of water. 0.1 ml serum plus 2.9 ml of water plus 0.5 ml of 0.3 normality barium hydroxide plus 0.5 ml of zinc sulfate mixed and centrifuge. The supernatant is used for the assay. Normal value is 90 to 520 milligram per deciliter. The method can be used for the estimation of semen fructose. Glucose tolerance test. A normal person should be able to reduce glucose load from the blood within the specified time. This is known as a normal tolerance. If the person has elevated blood glucose concentration for longer than the normal time, the condition is called reduction tolerance. If the glucose concentration becomes very low or normal very early than the normal time, then the condition is called as an increased tolerance. The tests that are used to measure these changes in blood glucose after the glucose load or called as glucose tolerances. There are two types: oral and intravenous. They are mainly used for the detection of diabetes. Oral GTT is commonly used in all laboratory. It is convenient to give the glucose through the oral. Indication of GTT: family history of diabetes, mellitus signs and symptoms comparable with the diabetes without complication, glucosuria, patients with normal fasting blood sugar, borderline postprandial blood sugar, reactive hypoglycemia for 3 hours or long period after for food taken, pregnancy with history of absorption, stillbirth or baby large baby preparation. Factors affecting GTT. The factors associated with the hyperglycemia: aldosterone, catecholamine, diphenyl hydantoin, nicotine, oral conceptives, thiazine, glucagon, and growth hormones. A factor associated with the hypoglycemia: ethanol, INH, and sulfonamide drugs. The age factor is also important. Glucose tolerance tends to become lower in old age. The fasting blood sugar for method, the fasting blood sugar and urine is then for the test is usually carried out in the early morning after fasting. Overnight fasting blood sample and urine is then collected. 75 milligrams of glucose dissolved in 150 to 200 ml of water is given to drink. A venous blood of estimation of blood is collected half an hour interval for 2 to 2.5 hours and hourly interval for 3 hours after the ingestion of the glucose. Urine specimen are also collected at the same time. The blood glucose is estimated in each samples and urine is tested for the presence of sugar. Comments: some prefer the administration of the 1.75 grams per kilogram body weight for glucose. However, the amount of the glucose taken very little difference to the response to the test. It is preferable to give 100 ml of water after ingestion of the glucose, which takes away the sweet taste and decreases the risk of vomiting. Plasma samples are more satisfactory than whole blood for glucose analysis because the plasma gives more reliable results and it is independent of hematocrit values. The variations of hematocrit values can be accounted for the difference in whole blood glucose value. Interpretation: normal glucose with normal curve has the following features. The fasting blood glucose in this category is usually within the range of 60 to 100 milligram per deciliter. The blood glucose does not give rise to 160 milligram per deciliter. The blood glucose at 2 hours after the load is 110 milligram per deciliter. The urine remains free of glucose throughout the test. The time of peak value is not defined as a part of normal pattern of response, but it is usually seen either in 30 minutes or 60 minutes of blood samples. Abnormal glucose tolerance response: reduced glucose tolerance. The main features are fasting level is about 120 milligram. The glucose level across 200 milligram per 100 ml is 30 to 60 minutes. The blood glucose level is more than 110 milligram per deciliter even after 2 hours. There may be glucose in at least 2 urine samples. Condition associated with diminished glucose tolerance: due to the lack of insulin, there will be decreased tissue utilization of glucose, which is seen in diabetes mellitus. Increase gluconeogenesis and gluconeogenesis seen in glucocorticoid excess and hyperthyroidism. Increased rate of absorption, which is seen in thyrotoxicosis. Decrease glycogen storage, which is seen in severe hepatic disease and glycogen storage diseases. Increase glucose tolerance. Glucose tolerance curve is characterized by the flat response. The condition associated with increase in tolerance of hypothyroidism, hypoadrenalism, hypopituitarism, malabsorption from the gastrointestinal tract, renal glycosuria, hyperinsulinemia. This is also characterized by fasting hypoglycemia, slight increase in blood glucose following glucose ingestions. Intravenous glucose tolerance. The preparation of patient. Poor absorption of oral given glucose may result in flat tolerance curve. Some patients are unable to tolerate large amount of carbohydrate load. In these patients, an intravenous glucose tolerance test may be performed to eliminate the factor related to the rate of glucose absorption. The test is used also to monitor the first phase of insulin response in the clinical studies. The preparation of the patient is the same as of oral GTT. Dose of glucose 0.5 grams per kilogram body weight, 25 grams per deciliter solution. The dose is administered intravenously over 3 minutes through one hand, and blood is collected at every 10 minutes from the opposite arm after the mid injection time for 1 hour, and the rate of glucose clearance is calculated. Spot test: the single blood test sample is collected for glucose estimation after the 50 grams of glucose load orally. Exactly 1 hour after the glucose load, the blood sample is collected for the glucose estimation. The glucose must not cross the upper limit. The random glucose is that is 150 milligram per deciliter. If the glucose level crosses 150 milligram per deciliter, then perform the oral GTT for confirmation. Diabetes mellitus. It is a group of metabolic diseases in which a person has a high blood sugar, less than 120 milligram per deciliter, either because of body does not produce enough insulin or because the cells do not respond to the insulin that is produced. Some patients may develop life-threatening conditions like ketoacidosis or coma, and the diabetic patients are increased risk of developing specific complications such as retinopathy, which leads to the blindness, renal failure, nephropathy, neuropathy, and atherosclerosis. Lost complication may result in stroke, gangrene, and coronary diseases. There are mainly two types of diabetes: insulin dependent diabetes mellitus, the type 1 or juvenile onset diabetes, non-insulin dependent diabetes, type 2 or adult onset diabetes mellitus. Insulin dependent diabetes, mode of inheritance, not transmitted disease, genetic predisposition. This comprises about 5 to 10% cases of diabetes mellitus. The parents usually develop the following symptoms: polyuria, polydyspia, polyphagia, and weight loss. The polyuria, the large amount of glucose may be excreted in the urine. Along with the glucose, water is also excreted due to the osmotic disease. Therefore, the large amount of urine excreted, and this condition is called the polyuria. Polydyspia, loss of fluid stimulates thirst center. Hence, a person drinks more water than normal, and this condition is called polydyspia. Polyphagia, since lipid and protein breakdown is increased, weight loss is common. Person eats more frequently, and this condition is called the polyphagia. Patients may have boils, abscesses, cellulitis. Patients have deficiency of insulin and are dependent on insulin to obtain life and prevents ketosis. Onset usually occurs in children, youth less than 20 years old. Evidence suggests that most patients with type 1 diabetes have acute immune destruction of beta cells on pancreas. The complication of this type is cataract, neuropathy, and nephropathy. Non-insulin dependent diabetes type 2, the mode of inheritance, the weight gain, and obesity, excess sugar in bloodstream. This group comprises approximately 90% of diabetes populations. The patients have minimum symptoms and usually not prone to ketosis. The patients are not dependent on insulin to prevent ketosis. Serum insulin level may be normal or may fluctuate. Most of the persons with NIDDM have impaired in insulin actions. The obesity is common with the NADDM, and weight reduction usually improves the hyperglycemia. Many people with NADDM may request the diet changes or oral hypoglycemic agent or insulin to control the hyperglycemia. Usually occurs after the age of 40 years. Sometimes occurs in the young people also. Symptoms and of diabetes: frequent urination, excessive thirst, extreme hungry or constant eating, unexplained weight loss, presence of glucose in urine. Diagnosis of diabetes depends on the demonstration of hyperglycemia. For the type 1, the diagnosis is easy because of hyperglycemia is more severe and is composed of serious metabolic disturbance. Checking for diabetes: the person of diabetes should be checked in person with the following characteristics. All adult older than 40 years of age should have a measurement of fasting blood sugar every 3 months. The person with a body mass index of 25 kg per meter square or above. The person with family history of diabetes. Individual with history of gestation diabetic. Delivery of a baby with high serum triglyceride level. Individual with HDL less than 35 mg per deciliter. The people with history of impaired glucose tolerance or impaired fasting glucose. Elevated fasting glucose or more than occasion. Treatment: monitoring blood glucose level, diet, exercise, medications. Type 1, daily insulin injections. Type 2, weight loss, alternative medicines. Diabetes due to secondary cause of symptoms. In some people, the glycemia is due to the specific disorder. This includes pancreatic disease with endocrine insufficiency, where insulin secretion or markedly decreases. Cushing syndrome, in which there is excessive secretion of glycocorticoids. Acromegaly, where there is excessive secretion of growth hormones. Excessive secretion of glucagon due to a tumor of pancreas. Hyperaldosteronism, excessive productions of aldosterone, metabolic changes in diabetes mellitus. Hyperglycemia causes decrease or impaired transport of uptake of glucose in muscles and adipose tissue. Decrease activity of key glycolytic enzymes. Increase glyconeogenesis due to lack of insulin. Increase amino acids of blood acts as a source of gluconeogenesis. Protein metabolism, protein synthesis decreases in all tissues due to the decreased production of ATP and absolute or relative insulin deficiency. Fat metabolism, the fatty acid synthesis decreases. Lipid breakdown is increased. Fatty acids are broken down to give large number of acetyl CoA. In the deficiency of insulin, acetyl CoA will enter the pathway of cholesterol synthesis or ketone formation. Therefore, the cholesterol is increasing in those with diabetes mellitus. Glycogen metabolism, the glycogen synthesis decreases. This is because of the decreased activity of glycogen synthesis due to the insulin deficiency. Glycosylated hemoglobin HbA1c level increases 3 to 4 days in untreated diabetes mellitus. Sorbitol pathway. The hyperglycemia leads to the conversion of glucose to sorbitol. Clinical complication of diabetes mellitus. If diabetes is not controlled, one has to face major complications of diabetes mellitus. Retinopathy, neuropathy, angiopathy, nephropathy, increases susceptibility to infection. Hyperlipidemia, ketoacidosis, hyperglycemic, non-ketolytic coma, except hyperglycemic, non-hemolytic ketotic coma are seen frequently in type 1 diabetes mellitus. Most of the following complications are seen in uncontrolled diabetes. Retinopathy, hyperglycemia leads to the sorbitol formation. This may lead to the retinal microvascular abnormalities. It is in turn may lead to the retinopathy and blindness. Neuropathy, it is the most common complication of diabetes mellitus. It is identified by the variety of symptoms like pain, numbness, tingling or burning sensation in extremities, dizzying and double visions. The secondary manifestations of neuropathy includes cardiac failure, excessive sweating and impotency. Angiopathy, it means damage of a basement membrane of blood vessels. Angiopathy increases the risk of stroke and coronary artery disease. It may cause atherosclerosis. Medium sized arteries like cerebral arteries, coronary arteries or peripheral vessels. If small vessels are affected, it is called as microangiopathy. Microangiopathy may lead to the diabetic retinopathy and nephropathy. Nephropathy, damage of glomerulus or nephron of the kidney and associated capillaries. The damage leads to the decreased filtering capacity of the kidney. The capillary damage is caused by the angiopathy, which is common features of diabetic nephropathy. Urinary proteins, examination of urinary proteins used for the diagnosis of nephropathy in diabetic patients. Normally, urine albumin excretes less than 150 milligram per day. If it is more, it indicates nephropathy. Hyperlipidemia and atherosclerosis. The serum cholesterol, TGL and VLDL level are increased in type 2 diabetes mellitus. HDL decreases in diabetes. All these factors increase the risk of atherosclerosis in diabetes. Diabetes ketoacidosis, deficiency of insulin activity in diabetes increases the lipid breakdown. The lipid breakdown increases the concentration of acetyl CoA. In normal conditions, acetyl CoA combines with alkaloacetate and enters the curve cycle for energy production. In diabetes, insulin deficiency causes depletion of oxaloacetate. Therefore, the acetyl CoA cannot enters the Krebs cycle, so it enters the alternative pathways such as cholesterol formation or ketone body formation. Therefore, the cholesterol and the ketone body increases in the blood. Increased ketone body level in the blood is called as ketonemia. Ketonemia leads to the excretion of ketone bodies in the urine, and the condition is called as ketonuria. The person's breath smell of acetone. The condition of ketone anemia, ketonuria, and acetone smells of breath together constitute the condition called ketosis. The accumulation of acetic ketone bodies the blood decreases its pH, resulting in the metabolic acidosis. Since it is seen due to the diabetes, it is called as a diabetic ketoacidosis. Keto bodies are excreted as their sodium or potassium salt. This leads to the loss of base from the body. To compensate for this, hyperventilation occurs. This is called as acidotic breathing or Kussmaul respiration. If the person is not treated properly, he or she may enter unconscious state, coma, or death. Hyperglycemic, hyper or smaller non-ketotic coma. It is characterized by the glucose level above 600 mg per deciliter. Blood pH is normal or slightly decreased. Keto acids are normal. Serum osmolality is above 350 milli-osmolaltic per kilogram. The osmotic dysuria due to the glucosuria causes severe water and electrolyte depletion. Coma results from the dehydration of cerebral cells. Even though diabetic ketoacidosis is commonly in type 1, the HHNC is primarily seen in type 2. So the condition is common in older patient. Giving hypotonic intravenous drug with the insulin treats this lactic acid acidosis. It is caused by the accumulation of lactic acid. Accumulation of lactic acid occurs due to the overproduction of utilization of acetic acid. Lactic acidosis may be seen in diabetic patients treated with hypoglycemic drugs such as bigonides and fenformins. These drugs inhibit the gluconeogenesis and disease cycle. Infection diabetes are highly susceptible to infections, ulcerations, and gangrene in the extremities. Skin orders are more commonly seen in diabetes than in non-diabetic pregnancy. In an uncontrolled diabetic mother, fetal abnormalities, premature birth, big babies, chance of abortions, intrauterine death of fetus, and hypocalcemia may occur. Gestation diabetes. If the carbohydrate intolerance is noticed for the first time during the pregnancy in non-diabetic women, it is referred as gestational diabetes mellitus. A non-diabetic patient who becomes pregnant, it is not included under this category. If the fasting blood sugar value is more than 130 milligram during the pregnancy, it is considered as a gestational diabetic. The frequency of abnormal glucose tolerance during the pregnancy ranges from 1 to 15%, but incidence of gestational diabetes mellitus is 1 to 5%. The glucose tolerance may come to normal after delivery or during the pregnancy itself. The strong family history of diabetes, mental history of stillborn or neonatal death, the history of bearing a infant with congenital anomaly, or the close suggestive of gastrointestinal diabetes mellitus. Delivery of large babies is one of the result of gestational diabetes. Symptoms of gestational diabetes are mild. It is not expressed in mothers, but it is associated with increased incidence of congenital malformation, increased risk of recurrence of diabetes after 10 years of parturition, and prenatal maternity. Early diagnosis and control during the 8th and 12th week of pregnancy can significantly decrease the risk of congenital malformation. A spot test is preferred test in the beginning to screen the gestational diabetes mellitus. The spot test is performed between 24th and 28th week of gestation on all pregnant women. Glucose load of 50 grams given orally irrespective of time or a meal. Determine the plasma glucose after 1 hour of the glucose load. Oral GTD is preferred when the estimated spot test blood glucose level rises about 150 milligram per deciliter. Diagnosis of gestation diabetes with GTD. Performed oral glucose tolerance test in the morning after 10 to 12 hours of fasting. Measure the fasting blood plasma. Give 75 or 100 grams of glucose orally. Collect the blood and urine samples simultaneously at interval of 1 hour. Measure the plasma glucose in all blood samples. Also check the urine for the presence of glucose. Positive glucose gestational diabetes mellitus presents the value shown fasting 110 milligram per deciliter, 1 hour 190 milligram per deciliter, second hour 165 milligram per deciliter, third hour 145 milligram per deciliter. At one of the urine sample must be positive for Bendix test. If the results are normal in clinical suspected case, repeat the test during the third trimester. Glycosylated hemoglobin to which glucose is bound. Glycation is one of the non-enzymatic processes where the addition of sugar residue to the amino group of a protein or takes place. Glycosylated hemoglobin is tested to monitor the long-term control of diabetes mellitus. The level of glycosylated hemoglobin is increased in the red blood cells of a person with poor control diabetes mellitus. The formation of glycosylated hemoglobin is irreversible process, and the blood level depends on both the lifespan of red cells and the blood plasma concentration. Since the glucose stay attached to the hemoglobin for the life of the red blood cells, the level of glycosylated hemoglobin reflects the average blood glucose level over the past 3 months. The human adult usually consists of HbA1 97%, HbA2 2.5%, and HbF 0.5%. The value of glycated hemoglobin are free of day-to-day glucose fluctuations and unaffected by exercise or food ingestion. Glycated hemoglobin test is recommended for both checking blood sugar control in people who might have pre-diabetic and monitoring blood sugar control in patients with more elevated level termed diabetes mellitus. The glycated hemoglobin is also known as glycohemoglobin or hemoglobin A1C. Determination of glycated hemoglobin by affinity chromatographic technique. The affinity gel column are used to separate a bond glycosylated hemoglobin from the non-glycosylated form fractions. A gel containing immobilized M-aminophenyl boric acid on cross linked beaded agarose. The boric acid reacts with the cis-diol group of glucose bound to the hemoglobin to form a reversible 5-membrane ring complex, thus selective holding the glycosylated hemoglobin on the column. The non-glycosylated hemoglobin is eluted. The complex is next dissociated by sorbitol, which permits the elution of a glycosylated hemoglobin. The absorption of the bound and non-bound fractions measured at 415 nanometer is used to calculate the percentage of glycated hemoglobin. Major advantages of affinity of no interference from non-glycosylated hemoglobin, negligible interference from the liable interference from the HbA1c, and the method have been significant in some details. Specimen: venous blood in the tube containing EDTA, heparin or fluoride mixed well. Whole blood can be stored at 4 to 4 degrees centigrade for 1 week. Reference range. The value of glycated hemoglobin are usually expressed as a percentage of page number 92. The values of glycated hemoglobin are usually expressed as a percentage of total blood hemoglobin. Based on several studies of normal subjects, suggested the following reference: HbA1c 5 to 8 percentage, HbA1c normally 3 to 6 percentage. Reference range may increase with the age in agreement with a similar observation of fasting blood sugar level in poorly controlled patients with diabetes mellitus, where values may extend twice the upper limit or more, but rarely exceed 20%. The value of over 20% should be prompted further studies to determine the possible presence of HbF if this is followed by the to interfere this method. Hypoglycemia: this is the condition where blood glucose concentration is below the fasting range, but it's difficult to define the specific limit. A decline in the glucose may be seen 2 hours after the meal, and often plasma glucose level is as low as 50 mg per deciliter. It may be observed either after oral glucose load. There are no symptoms which are specific for hypoglycemia. The classical signs and symptoms of hypoglycemia are weakness, sweating, nausea, rapid pulse, and epigastric discomfort. These symptoms may also be noted in other conditions such as hyperthyroidism, pheochromocytoma, and anxiety. The gradual onset of hypoglycemia may not produce as symptoms. The brain mainly depends on the blood glucose and very low level of plasma glucose and causes severe central nervous system dysfunctioning. During the prolonged hypoglycemia, the ketone bodies are storage of energy. The key and symptoms with prolonged hypoglycemia are headache, confusion, giddiness, lethargy, seizure, and may develop and leads to the loss of consciousness and even death. These symptoms are known as neuroglycopenia. The most common hypoglycemia is reactive hypoglycemia due to the symptoms that occurs 2 to 3 hours of food intake. The symptoms are usually mild and gradually causes serious diseases. The glucose concentration in neonate is much lower than the adult, and it declines shorter after birth when liver glycogen is depleted. Reactive hypoglycemia is a clinical disorder in which the patient has a postprandial symptoms after normal food accomplished by the blood glucose level 45 to 50 mg per deciliter. It is important to rule out fasting hypoglycemia before diagnosing reactive hypoglycemia. Reactive hypoglycemia is a beginning condition that may be considered as a variant of normal physiology. The best diagnostic test for reactive hypoglycemia is to obtain blood samples when a patient has symptoms. Blood glucose normal range demonstrates that the symptoms are not due to the hypoglycemia. Blood glucose regulation. Blood glucose is regulated by several metabolic pathways which are mainly modulated through the many hormones. The major pathway or glycolysis, the glycogenolysis, glyconeogenesis, glycolysis and oxidation of carbon dioxide and water occurs through the TCA cycle. Oxidation of carbon dioxide and water also occurs by monophosphate shunt pathway. During the brief fast decrease in the level of blood glucose is prevented by the breakdown of glycogen stored in the liver. A small amount of glucose may also be derived from the kidney. The liver glycogen contributes glucose through the glycogenolysis. The liver and kidney contains glucose 6-phosphate which converts glucose 6-phosphate to glucose, which is through the gluconeogenesis. The glucose phosphate enzyme is absent in skeletal muscle, so a muscle glycogen cannot contribute directly to the blood glucose. If the fasting condition prolongs, the gluconeogenesis plays a role in maintaining blood glucose level. In contrast, after the meal, the absorbed glucose is converted to glucogen for storage in liver and muscles, or fat for storage in adipose tissue. During the fluctuation in supply and demand of carbohydrate, the glucose concentration is normally maintained within the range of by hormone, which modulates the movement of glucose into and out of the circulation. The insulin is the main hormone which decreases the blood sugar. Hormone like glucagon and growth hormone increases the blood sugar level. Postprandial blood sugar reductions after the meal or break fast, the absorption of glucose from the intestine increases blood glucose. Increased glucose level in the blood stimulates beta cells of pancreas to secrete insulin. The insulin promotes the uptake of glucose by tissue and promotes lipogenesis. Therefore, glucose level is regulated at a normal range. Fasting blood sugar regulations. In normal condition, 4 to 5 hours after the meal, blood glucose level decreases near to fasting level. Further decrease in blood glucose is prevented by hyperglycemic conditions. Hyperglycemic hormones which stimulates liver glycogenolysis. If fasting is prolonged, glucose is by gluconeogenesis pathway. The liver is a central organ which maintains the blood glucose level. Normal blood glucose level. If glucose is estimated in a post-absorptive state, that is an overnight fast of 12 hours, it is called as a fasting blood sugar. In a normal person, the fasting blood sugar level is 70 to 100 milligram per deciliter. The plasma values are slightly higher than the whole blood glucose, since RBC contains 73% of water compared with 93% of water of plasma. The blood glucose is estimated 2 hours after the meal. It is called as a postprandial blood sugar. In normal person, PPBS level is 90 to 140 milligram per deciliter. If the blood glucose is estimated randomly, it is called as a random blood glucose. The normal blood glucose level is 90 to 150 milligram per deciliter. When the blood glucose level is in the normal range, it is called as normoglycemia. Increase in blood glucose level above the normal level is called a hyperglycemia. It is a harmful condition. Decrease in blood glucose level above 50 milligram per deciliter is called hypoglycemia. Prolonged hypoglycemia is fatal. In normal condition, glucose is not not be excreted in the urine. Excretion of glucose in urine is called as a glycosuria. Blood glucose regulation by hormones. Insulin is a peptide hormone produced by beta cells of Langerhans of pancreas. Human insulin contains 51 amino acids in 2 chains, namely alpha and beta, joined by 2 disulfide bridges with a molecular weight of 6,000. The carboxy terminal region of beta chain appears to be the crucial for the biological action of insulin. Insulin from most animal is immunologically and biologically similar to human insulin, and all insulin dependent patients were treated with pure insulin obtained from beef or pig pancreas. It is an anabolic hormones which stimulates the uptake of glucose into the muscles and other tissues. The insulin promotes the conversion of glucose to glucagon or fat from storage. It inhibits the glucose production by liver through gluconeogenesis and glucogenolysis. It also stimulates the protein synthesis and inhibits protein breakdown. Glucagon, the polypeptide hormone secreted by alpha cell of pancreas, it stimulates the production of glucose in the liver by gluconeogenesis, and gluconeogenesis it inhibits glycolysis. Depression of glycogen synthesis. Insulin antagonizes the effect of glucagon and also inhibits the glucagon release from the pancreas. Epinephrine. This is a catecholamine hormone secreted by the adrenal medulla. It stimulates the glucogenolysis and decreases the glucose utilization. It stimulates the glucagon secretions and inhibits insulin secretion by pancreas. Growth hormone, the polypeptide hormone secreted by the anti-pituitary gland. It stimulates the gluconeogenesis and lipolysis. It is antagonizes insulin synthesis, glucose uptake. Cortisol secretes by the adrenal cortex, stimulates the gluconeogenesis, increases the breakdown of protein and fats. Thyroxine secretes by the thyroid gland, increases the rate of intestinal glucose absorption. Somatostatin, a polypeptide hormone found in the several areas of body, but it is concerned in the hypothalamus and the cells of pancreas. It inhibits the related of growth hormone. It also decreases the secretion of glucagon and insulin by pancreas, motivating the reciprocal relationship of two hormones.